Thank you, Dr. Khanna. It's indeed a pleasure to be associated with APVIC, and thank you, Dr. Mahapatra, for this opportunity. So, what we shall be discussing is understanding the concept, the application, and interpretation of CT in cardiovascular disease. Now, I'm going to start with the cardiac part of it. So, the biggest indication for cardiac CT we know is ischemic heart disease. And the role of cardiac CT is really one, for risk stratification in the asymptomatic individual, second, to guide management in the stable symptomatic patient, and the third is to predict outcome. So, if we start with the asymptomatic individual, the first step of a cardiac CT is the calcium score. And the fact is that the coronary calcium is not an aging phenomena. It occurs exclusively in the atherosclerotic arteries, and the calcium score is actually an automated software. It gives us the distribution, density, weighting, and size of the coronary calcium. The scan is a very easy scan. It's a rapid acquisition, takes about 10 seconds, does not require contrast. There's no IV line, no patient preparation. It's a very low radiation dose. It has a very strong prognostic predictive value. It's inexpensive, reproducible, and easily interpretable. And the coronary calcium is significantly superior in predicting cardiac events in the asymptomatic women, men, and diabetics over the Framingham risk score. And this is irrespective of ethnicity or color, as was demonstrated in the MESA trial. And it's also irrespective of the burden of dyslipidemia and regardless of how dyslipidemia is classified. The calcium score also significantly improves risk stratification, not only beyond the FRS, but also the exercise treadmill test. So how should we be interpreting the calcium score? We have two ways, the absolute or the percentile score. While absolute risk stratification categories do exist, but what we're really interested in is the percentile score, because it's the rate of change which is important. If at 40, the calcium score is that of a 60-year-old, then the rate of accumulation is faster. We want to aggressively treat it. And even if the absolute score looks good, we need to slow down the rate of progression. Going on to guiding management in the stable symptomatic patient, the issue is that a stable chest pain is always a challenge for the cardiologist because the symptomatology, the clinical workup, the serum markers, and the ECG are not all totally reliable. And the spectrum can be all the way from normal to severe and critical disease. The need is for a fast, reliable, and accurate non-invasive tool to help not only rule out coronary artery disease, but to aid in diagnosis by checking on the extent and severity of anatomical and flow-limiting lesions, to predict outcome, guide management, and exclude other non-cardiac causes of chest pain. In the armamentarium of tests that we have the anatomical evaluation of the coronaries, where the gold standard is the invasive CAG, but we also have the non-invasive CT angiography as the second test. Then we have the functional evaluation, which I'll come to later. The chosen test must at one end reliably rule out coronary artery disease and at the other end of the spectrum be able to give us an accurate diagnosis for extent, severity, anatomical flow limiting lesions to guide management and whether the patient needs to go to an urgent cath. So as far as ruling out coronary artery disease, the diagnostic performance of coronary CTA is outstanding with a very high negative predictive value and a sensitivity of over 94%. And if you have pristine coronaries like this, there's extensive literature to support that there is a very high negative predictive value of over 99% to rule out coronary artery disease, which is why the CTA has been in the appropriateness criteria for the low to intermediate pretest probability of coronary artery disease. But is CTA only useful for its negative predictive value? How reliable is it in the diseased coronaries? With advances in CT technology, we now have faster acquisition, wider scan range with a high spatial and temporal resolution and dual energy spectral capabilities with advanced post-processing. We have the capability of excellent assessment of the coronaries with very few non-accessible segments, and even single-click images will give us the central line and stenosis assessment together with the coronary tree extraction. The softwares give us the coronary ribbon view, and then we have softwares which estimate not only stenosis but plaques and everything now. Can CT actually have an incremental benefit over the gold standard ICA? Here in this patient, you can see that there is a significant LCX stenosis but at the same time, there is also an RCA plaque. So the patient was referred for a PCI for the culprit lesion, which was the LCX stenosis. On the CAG, there was a single vessel disease, and the pre and post PCI images of this patient are demonstrated. Definitely for the coronary stenosis, CTA to ICA had an excellent concordance in the detection of the culprit lesion. So compared to other non-invasive modalities, CTA is better than most of them in the detection and exclusion of obstructive coronary artery disease. But what is the therapeutic consequence of stenosis? Because we do know that majority of the lesions causing MI are not high grade. And not often, or in fact, more frequently, we find that most of the acute MIs and sudden cardiac deaths are caused by low-grade plaques and not stenosis. When we talk about acute MI, not infrequently, it's the plaque rupture which accounts for 70% of the fatal MIs. And what constitutes this vulnerable plaque that can rupture? These are usually the low attenuation lipid-rich intraplaque cores with positive remodeling, spotty calcification, napkin ring sign, and serial plaque progression. And this is exactly what we saw in the RC of this patient. Disadvantage of CAG is that it is the gold standard, but it's only a luminography. So it's not really going to show you the plaque in this manner. Whereas CTA gives you the luminography and more. It shows us the stenosis and also the cause of the stenosis. And the presence of any atherosclerotic plaque actually prognosticates adverse outcome. So even a mild plaque may have 6 times higher mortality for patients with triple vessel disease. And in fact, these plaques predict better than all clinical findings and stenosis. The second part of the management of ischemic heart disease is the functional imaging, because we need a hybrid imaging. We want both the anatomical and the functional aspect. So when we look at the functional aspect, we're talking about the impact of the stenosis in myocardial ischemia, infarction, LV function. And here, while the gold standard is the invasive FFR, we have the non-invasive competitors such as echo, SPECT, PET, MRI, with and without stress. Ischemia-guided revascularization, we know, improves event-free survival. So checking for ischemia is important, and CT allows us to do myocardial perfusion in a static and dynamic format. Here you can see that there is a complete reversible ischemia between stress and rest images of the CT perfusion. And the interpretation of perfusion is similar to most modalities, be it nuclear medicine, MRI, or CT. We're looking at a reversible defect, a fixed defect, or a partially reversible defect between stress perfusion, rest perfusion, and delayed enhancement in order to diagnose stress-induced ischemia, myocardial infarction, or peri-infarct ischemia. Combining CT and CTP definitely has its advantages because it gives us an incremental benefit with a sensitivity of 100% and a negative predictive value of another 100%. Recent advances in CT allow the CT FFR to be calculated in a non-invasive fashion from the entire coronary bed based on the classic CT. And the CT FFR is superior to all other non-invasive modalities for lesion-specific ischemia. The third part is in the role of cardiac CT is to predict outcome. And that can be an immediate outcome where I think the CTOs are what CT really benefits from. Because CT can help you assess the lesion length, the tortuosity, calcification, the distal vessel visibility, which then helps in giving you a success rate of intervention, particularly in the CTOs. Also, in the long-term outcome, you have CT, which looks at regional and global LV function based on automated contour tracking, functional evaluation, wall motion, wall thickness, perfusion defects, and delayed enhancement. And all these impact the long-term outcomes. It also helps in complications. So not infrequently, we see on CT the wall thinning, the fat replacement, and we may find an apical thrombus in the LV. Post-intervention, CT can evaluate stents and grafts in exceedingly good fashion. And here you can see the post-intervention complications. This patient had an in-stent restenosis. Here you have a post-PTCA persistent abscess, while here it's a post-CABG graft stenosis. So CT definitely has the potential for a one-stop shop for imaging in ischemic heart disease, from the coronaries to function to perfusion. Let's now go to the front in the cardiovascular aspect. We finished the cardiac, but let's go to the vascular aspect. And non-invasive imaging of the aorta is exceedingly important today. The challenge of aortic diseases are that they manifest as catastrophic emergencies, and time is critical in these patients. So we need a prompt and accurate diagnosis. CT today is the modality of choice because the symptoms can actually be misleading. And while we have a high reliance of various imaging modalities, CT has emerged as the winner. When we're looking at the CT of the aorta, the advantage is that we have a large volume coverage, a short acquisition time, a very high spatial resolution with homogeneous contrast enhancement and isometric acquisition. So that allows post-processing. So we can actually get multi-format reformats from central lines to curved reformats and then volumetric images. Serial monitoring also becomes easy because the prognosis and optimal timing for surgical intervention is dependent on various measurements, and you can actually have side-by-side comparison of source axial images from different times. The protocol used is usually a gated CT of the thoracic aorta and a non-gated study for the abdominal aorta. How do we measure the aorta? You always have the systolic and the diastolic phases, and the systolic is preferable because they're usually different in size. The edge selection, again, needs to be very carefully done because it's always the external surfaces that we measure in order to avoid confounding by intra-aortic thrombi or atheromas. Oblique imaging can also overestimate the aortic dimensions, and so we really need to know how we've taken the central line. The aortic root is measured in the true double oblique plane, and that's really for the TAVR measurements when we're doing the annulus, the cusps. So here is the annulus measurement we're looking at. Then we have the aortic root, the sinus of Valsalva, the sinotubular junction, the aorta, the height of the coronaries, LVOT, and all that can be assessed. Thoracoabdominal aorta can also be looked at in order to look at the iliofemoral axis. The upper limits of normal for aortic dimensions have been documented at various levels. When we talk about the acute aortic syndrome, the gamut of conditions includes the aortic dissection, the intramural hematomas, the penetrating ulcers. Then we have traumatic transections and ruptured aneurysms. Starting with acute aortic dissections, the CT becomes the modality of choice where we can see not only the flap, we can see the entry, the re-entry sites, the extension into branch vessels, the end organ ischemia, and the extravasation. The classification, as we all know, can be the Stanford or the DeBakey type. And here you can see a Stanford type A with involvement of the ascending aorta with an extensive flap. Here is the entry tear delineation where you can see that where the entry is. This is a type B aortic dissection where the entry is distal to the left subclavian. And the differentiation of the true and false lumen can be easily done on CT, where the true lumen is often smaller. Its origin of the visceral arteries arises from the true lumen usually.
Sorry to interrupt, Dr. Mona. The time is up. Please conclude as we have to be in the time for the next session, please.
Okay. So then we're looking at malperfusions where we're looking at coronaries. We can have obstruction to various vessels and we can have malperfusion to various organs. Intramural hematomas can all be evaluated, as can penetrating ulcers. And again, for aneurysms, we have a very good method by which we can actually evaluate and treat or watch depending on what is the size. EVAR today is an excellent alternative to surgical repair. And again, we're looking at the size, the extent, the angulation, the landing zone, and all these can be evaluated by CT. Going on to how CT helps, well, CT versus MRI and versus other modalities, CT has emerged as the winner. And in the pre-therapeutic aortic evaluation, there is no doubt that CT angiography is the modality of choice when provides an accurate assessment of the diagnosis, serial monitoring, prognosis, and management. Thank you so much for your patient listening.
Thank you very much, Dr. Mona. That was wonderful. I also want to welcome at this stage our close friends, Dr. ML Bera, who was working in Apollo earlier, and he's the one with whom we actually started our endovascular work, and he used to be the backbone of imaging. We really miss him. And other close friend is Dr. Rabin Chakravarti, who is the president-elect for Indian College of Cardiology. Rabin, welcome. This is a very interesting symposium on non-invasive imaging of cardiovascular disease. So maybe we can have the questions in the end. So let me invite Dr. Jonan Christopher for his talk on understanding the concept and application and interpretations of cardiac MR.